Imagine going to the doctor for a major life transition. You roll up your sleeve for a definitive blood test to see exactly what is happening with your hormones, and the doctor just looks at you and says, actually, the medical guidelines explicitly tell me not to do that.
Yeah, I mean, it completely violates how we are conditioned to experience modern medicine, doesn't it? We always want the X-ray or the lab result, the definitive proof printed on a piece of paper.
Right, we want the math.
Yeah.
But when you step into the world of women's reproductive health, specifically the transition out of the reproductive years, that definitive diagnostic machine is just unplugged.
Completely unplugged. It's a huge shift.
It really is. So welcome to the deep dive. Our mission today is to cut through a landscape of diagnostic muddy waters to answer one very specific question. What is the precise medical definition of menopause?
And to find that answer, we are looking at a rather massive stack of official clinical guidelines.
Oh yeah, it's a big stack.
It is. We've got the protocols from the National Institute for Health and Care Excellence, which is commonly known as NICE, the consensus statements from the British Menopause Society, plus guidance from the Royal College of Obstetricians and Gynecologists and the NHS.
And the overarching theme in all these documents is just a massive paradigm shift.
Right.
Because the way most of us assume menopause is diagnosed, through a single validating hormone test, is completely contradicted by the actual clinical standards for the vast majority of women.
Right. And to understand why that blood test is, well, practically useless, we first have to establish what the actual medical finish line is.
Medically speaking, the baseline definition of menopause is the point at which the ovaries completely cease their reproductive function, right?
Exactly. They stop releasing eggs, and as a direct biological result of that, menstrual cycles just end permanently.
And looking at the data for the UK, the average age for crossing this finish line is 51, with the normal range falling anywhere between, I think it was 45 and 55.
Yeah, 45 to 55 is the standard clinical window. But there is a massive paradox in the guidelines here. Menopause is defined entirely in retrospect.
Wait, meaning you can't be diagnosed in the moment?
No, you cannot be officially diagnosed as postmenopausal until you have had absolutely no natural periods for 12 consecutive months.
12 whole months.
Yep. And that is provided you aren't using hormonal contraception, because obviously that alters your bleeding patterns and masks what your body is naturally doing.
So what is the biological reality behind that 12-month delay? Why not 3 months or 6 months?
Because the hormonal wind down of the ovaries is not a clean break. I mean, it is not a light switch flipping off. It is much more like a sputtering engine.
A sputtering engine.
Yeah, it revs up, it dies down, it surges, it stalls. And because of that profound biological unpredictability, a full 12-month gap is the only statistically reliable indicator that the cessation of ovarian function is truly permanent.
Oh, wow.
Because you could go, say, 11 months without a period, experience one, and the clinical clock completely resets to 0.
That is so frustrating. It's literally like crossing the finish line in a grueling marathon,
Sure.
but you only officially get your medal a full year later.
That's a perfect way to put it.
Which creates an obvious logistical problem for patients, right?
Uh-huh.
If the official definition requires waiting a full year in retrospect, what happens to the patient who is actively in the thick of that sputtering transition today?
Right. If a woman is 48, feeling awful, and her periods are chaotic, what do the guidelines say a doctor should do?
Exactly.
Well, this is where those NICE and British Menopause Society guidelines really shift the diagnostic paradigm. For women aged 45 and over, the guidelines explicitly dictate that perimenopause and menopause should be diagnosed based on clinical symptoms alone.
Symptoms alone, so no tests.
No tests. The routine laboratory tests used to measure follicle-stimulating hormone, which is often abbreviated as FSH, or tests to measure estradiol levels, are deemed clinically inappropriate for this age group.
I really want to dig into the why here.
Yeah.
Because, it feels so counterintuitive to ignore a hormone test for a hormone transition.
It does feel backwards.
Right. The guidelines note that these levels jump all over the place, but what is actually happening in the body to make the test useless?
So FSH, or follicle-stimulating hormone, is basically your brain shouting at your ovaries to release an egg.
Oh.
During a normal reproductive cycle, the brain shouts, the ovaries respond by releasing an egg and producing estrogen, and then the brain quiets down.
What's a feedback loop?
Exactly. But during this transition, when the sputtering ovaries don't respond to the signal, the brain panics. It shouts louder and louder, pumping out massive, erratic spikes of FSH to try and force the ovaries to work.
Oh, I see. So when a doctor draws blood to test FSH during this phase, they aren't measuring a nice, steady decline.
Not at all.
They're basically just measuring how loudly the brain happens to be shouting on that specific Tuesday.
Exactly that. It is a single snapshot of a moving target. And worse than that, if you are currently taking exogenous hormones like the combined contraceptive pill or even early hormone replacement therapy, those external hormones are actively suppressing your natural FSH levels anyway.
Oh, right. Because your brain thinks the estrogen's already there.
Right, so the blood test isn't even measuring your own baseline biological response. It's totally invalid.
So drawing blood to check FSH in a 48-year-old woman is basically like trying to measure the exact water level in a washing machine.
Well, it's mid-agitation cycle.
Right. The water is splashing everywhere. It is entirely chaotic. Sticking a ruler in there for a split second tells you absolutely nothing useful about the actual volume of water in the drum.
That's exactly it. And the medical community has realized that listening to a patient's lived experience is mathematically and clinically more accurate than trying to read that ruler.
Which is incredibly validating for the patient.
It is, and the guidelines specifically note that relying on symptoms avoids delayed treatment. You aren't forcing a patient to wait weeks for a follow-up consultation to discuss a confusing blood result that doesn't even reflect how they feel that day anyway.
Right. So if a woman is over 45 and has the classic symptoms, the directive is clear. Trust the symptoms, make the clinical diagnosis, and initiate the conversation about management immediately.
Immediately, exactly.
But because we are throwing out the blood tests and relying entirely on the lived experience, we have to look closely at what that symptomatic phase actually entails.
We do, because it's vastly misunderstood.
Yeah, this is the period medically termed perimenopause, right?
Yeah.
The time when estrogen levels first start to significantly fluctuate and decline, kicking off the physical changes.
Yes, that's the medical definition of the perimenopausal phase.
And looking at these clinical guidelines, the median duration for these symptoms is 7 years.
Median.
Wait, median?
Yes, meaning for a massive portion of the population, it is significantly longer than 7 years.
Oh, wow. That is an enormous chunk of a person's life to be symptomatic. And the medical definition of these symptoms goes so far beyond the cultural narrative of, just hot flushes and unpredictable periods.
Oh, it goes way beyond that. The clinical criteria require doctors to look for a vast array of systemic changes. Yes, the vasomotor symptoms, the hot flushes and night sweats are hallmark indicators, but the guidelines heavily emphasize musculoskeletal symptoms.
Which means what exactly?
We are talking about sudden, severe joint and muscle pain.
See, that is wild to me. If someone is 48 and their knees and shoulders suddenly start aching, they're probably going to think they just slept funny. Or worse, that they are just, quote-unquote, getting old.
Right, they misattribute it completely.
Why does a reproductive transition make your knees hurt?
Because estrogen is a master regulator of inflammation at a cellular level. Estrogen receptors are located all over the human body, not just in the reproductive system. They are deeply integrated into your joints, your muscles, your brain, and your cardiovascular system.
Really? I had no idea they were in the joints.
Oh, yeah. So when you experience a systemic drop in estrogen, your body's baseline inflammatory response flares up. Plus, you also experience a decrease in joint lubrication.
So it's a double whammy.
Exactly. That combination of systemic cellular inflammation and lost lubrication leads directly to widespread musculoskeletal pain.
So the estrogen is literally keeping the cellular fires put out.
Yeah.
And when it drops, the inflammation just spikes.
It does. And that same systemic drop impacts the brain, too.
Oh, the cognitive effects.
Yes. The guidelines highlight profound cognitive and mood effects. We are looking at new onset depression, severe anxiety, loss of confidence, and brain fog.
How is brain fog medically defined, though?
It manifests as distinct difficulties with short-term memory and concentration. And the British Menopause Society standards are very firm on this. Perimenopause must be considered in women over 45 who present with mood disorders experienced de novo.
De novo meaning for the first time.
Right, in the absence of any pre-existing clinical depression or anxiety.
So if you have never had clinical anxiety in your life, and at 46 you suddenly feel overwhelmed with daily panic, the medical guidelines instruct the doctor to look at your hormones first.
Yes, not just hand you an antidepressant.
That is such an important distinction.
It's vital. And the protocols also detail a critical category called genitourinary syndrome of menopause, or GSM.
Okay, this one blew my mind when I was reading the sources because it is so rarely talked about openly.
Extremely stigmatized, unfortunately.
Right. The guidelines list vaginal dryness, discomfort, and pain with sex, which, people might expect.
Yeah.
But they also list recurrent urinary tract infections.
Yes.
How many women are just endlessly taking antibiotics, assuming they have a chronic bladder issue, when it is actually a diagnosable biological symptom of perimenopause.
Far too many, which leads to massive overprescription of antibiotics.
So what's the connection there? Why the UTIs?
The tissues of the vagina and the lower urinary tract are highly dependent on estrogen to maintain their thickness, elasticity, and their natural defense mechanisms against bacteria.
Okay.
When estrogen drops, those tissues physically thin out a condition called atrophy. The local pH changes as well, making the entire area highly susceptible to recurrent bacterial infections and chronic discomfort. And unlike hot flushes, which often eventually subside after the transition, GSM symptoms typically worsen over time if the underlying estrogen deficit is left untreated.
That is just, knowing the true, precise medical scope of these symptoms is vital. You cannot advocate for yourself if you misattribute cellular inflammation, brain fog, and tissue atrophy to just general aging.
You really can't. You have to know the definitions.
But these rules, the reliance on symptoms and the ban on blood tests, they completely flip if the timeline falls outside that standard 45 to 55 window, right?
They do. When menopause occurs early, the diagnostic criteria entirely reverse.
Why is that?
Because it is biologically highly unusual for the ovaries to fail at a younger age. Doctors must confirm the diagnosis biologically to rule out other serious underlying conditions.
Let's define those shifted timelines for everyone. The sources categorize early menopause as occurring between the ages of 40 and 45, which affects about 5% of women. And then there is premature ovarian insufficiency, or POI. This is menopause occurring under the age of 40, affecting roughly 1% of women. Why does POI happen so early?
Well, POI can be triggered by several complex mechanisms. It is frequently linked to autoimmune disorders where the body's immune system mistakenly attacks the ovarian tissue.
Oh, wow.
Yeah, it can also be driven by genetic factors, such as chromosomal abnormalities like Turner syndrome or Fragile X mutations. Sometimes it is idiopathic, meaning the cause is unknown. But regardless of the trigger, the biological reality is an abnormal, premature failure of the ovarian function.
So for these younger patients, the washing machine analogy is just gone. We actually need the dipstick.
We do. For early menopause and POI, the clinical diagnosis absolutely requires elevated follicle-stimulating hormone levels. And to ensure they aren't just catching a random spike, the guidelines mandate this elevation be confirmed on at least 2 separate occasions, measured 4 to 6 weeks apart.
Okay, that makes sense. And the guidelines vary slightly on the exact threshold for that FSH test, right?
They do.
Some say anything over 25 IUL, others say over 30, and the NHS Highland guidance mentioned over 40 for POI. But the mechanism is universal, right?
Right. They're looking for a persistently high level of the brain shouting at the ovaries. And I should note, the NICE guidelines also explicitly state that anti-Müllerian hormone, or AMH testing, should not be routinely used for this diagnosis. It must be FSH.
No AMH, got it.
Yeah.
Now, there's one more major exception to the natural timeline, and that is surgical menopause.
Yes.
This is induced by a bilateral oophorectomy, which is the surgical removal of both ovaries, often performed during a hysterectomy or as a preventative measure against ovarian cancer.
Yeah, right.
With surgical menopause, do you still get that 7-year sputtering engine phase?
Not at all. You skip the perimenopausal fluctuation entirely. You go from a baseline of natural functioning hormone production to 0, essentially overnight.
Oh, man. That sounds violently disruptive to the body's systems.
It is an immediate severe plunge, and because of this sudden physiological shock, the symptoms are vastly more intense than in a natural gradual menopause.
I can only imagine.
The RCOG surgical toolkit notes that vasomotor symptoms hit with incredible severity. Furthermore, the abrupt loss of testosterone, which the ovaries also produce, leads to a drop in libido and sexual function that is much more prominent and sudden than what is seen in natural menopause.
So, pinning down exactly where you fall in this framework, whether you are under 45 needing blood tests, over 45 relying on symptoms, or navigating surgical menopause, isn't just about giving your suffering a clinical name.
No, not at all.
It dictates the entire medical playbook for what happens next. The exact definition and timeline completely determine the risk-benefit ratio of treatment.
Exactly. Identifying your place in this medical framework establishes what therapies are medically required to protect your long-term health.
So let's talk about that treatment.
Well, for POI and early menopause, the under 45 group, the guidelines don't just gently suggest hormone replacement therapy, they strongly recommend it as a standard of care.
Basically telling doctors you need to prescribe this.
Yep.
For women under 45, HRT is advised at least until the average natural age of menopause, which is 51. The primary clinical goal here isn't just stopping the hot flushes, is it?
No, it is preventative medicine. Without estrogen for that missing decade, these younger women face a drastically higher risk of severe osteoporosis, early onset cardiovascular disease, and cognitive impairment.
Oh, wow.
It is literally replacing what the body was medically expected to produce to protect those systems.
But for natural menopause, say, a woman who is 50, presenting with symptoms, diagnosed without a blood test, the treatment landscape is evaluated differently.
It is. The British Menopause Society consensus states that HRT prescribed before the age of 60 or within 10 years of the onset of menopause has a highly favorable benefit to risk profile.
Meaning the benefits of protecting your heart, your bones, and resolving the systemic inflammation heavily outweigh the risks.
Yes, initiating HRT within that specific window of opportunity is associated with a quantifiable reduction in coronary heart disease and overall cardiovascular mortality.
Okay, but we have to talk about the conflicting data in these sources, because it is incredibly dense and honestly pretty scary for a lot of people.
I know exactly what you're going to bring up.
Right. When people hear HRT, the immediate association is breast cancer risk.
Always.
I read the NICE CE surveillance report we have in the stack, and there's a massive contradiction regarding this. The MHRA, the Medicines and Healthcare Products Regulatory Agency, issued a drug safety update based on a new study involving over 500,000 women.
Yes, the 500,000 woman study.
And this study claimed that the excess risk of breast cancer with systemic HRT persists for more than 10 years after stopping the therapy. That sounds terrifying.
It does.
But then the same NICE document points out 10 other studies, including a recent one looking at over 1 million women, that show much smaller effects. Hold on.
Yeah.
How can a 500,000-person study say there is a major lingering risk, and a 1,000,000-person study say the exact opposite?
Wild, isn't it?
What is a patient or even a doctor supposed to do with completely contradictory science?
It is intensely frustrating for both patients and clinicians. And it really comes down to how these different studies were constructed.
Okay, break that down for me.
So the 500,000 woman study used a case control methodology. In a case control study, researchers start with the outcome. They gather a group of women who already have breast cancer, and they look backward in time to see if they took HRT.
Oh, I see.
This method is highly susceptible to confounding variables and recall bias. NICE had actually previously excluded this specific study design from their protocol because of these inherent flaws.
So they're basically looking backward through a blurry lens.
Precisely. Conversely, the 1 million woman study and the other newer studies NICE reviewed were cohort studies.
And how is that different?
A cohort study takes a massive group of healthy people, follows them forward over many years in real time, and watches who takes HRT and who eventually develops breast cancer.
So forward-looking versus backward-looking.
Right. Cohort studies are generally considered far more reliable for assessing this kind of long-term risk because you are tracking the data as it happens, not trying to untangle it after the fact.
Yeah.
Across all these massive cohort studies, the risk effects were consistently smaller. The NICE report acknowledges this outright, noting the sheer inconsistencies in the data.
So the data is conflicting based on how the math was done, but the overall medical consensus remains. For women under 60, the systemic benefits generally outweigh the risks.
Yes, that's the consensus.
However, it highlights the absolute need for highly individualized care. You have to look at your personal family history, your baseline health, and specific risk factors. You can't just take a generalized risk percentage at face value.
Exactly. And the guidelines offer concrete ways to mitigate the risks that do exist, specifically based on the route of administration.
How you actually take the hormone.
Right. The BMS consensus strongly dictates that transdermal estrogen, meaning estrogen delivered through patches, gels, or sprays on the skin, is the preferred clinical route over an oral pill.
I want to understand the mechanism there. Why does putting a gel on your arm carry less risk than swallowing a pill?
It comes down to how the body processes the medication. When you swallow an oral estrogen pill, it goes into your digestive tract and must pass through the liver before entering the rest of the body.
Okay.
The liver reacts to this sudden influx of oral estrogen by ramping up the production of clotting factors.
Oh, which increases the risk of blood clots.
Exactly. But transdermal estrogen is absorbed through the skin, entering the bloodstream directly. It completely bypasses that first-pass liver metabolism.
So the liver never gets flooded.
Right. The liver doesn't get flooded, the clotting factors aren't spiked, and therefore, transdermal estrogen does not carry the same increased risk of venous thrombosis, deep vein blood clots, or stroke compared to oral estrogen.
This is exactly why knowing the granular details of the medical definition matters. It is the key that unlocks the safest, most precise therapies.
Absolutely.
If you know the mechanisms, you know to go into your doctor's office and specifically ask for transdermal estrogen. You know that if you are 48 and experiencing cellular inflammation and brain fog, you do not need to accept a doctor telling you, well, let's wait for a blood test.
Right. Understanding these precise NICE and BMS standards prevents patients from being dismissed, misdiagnosed, or undertreated by practitioners who simply might not be up to date on the latest methodologies of menopausal care.
So let's recap the shifting definitions we've uncovered today. The strictly technical medical definition of menopause is a 12-month retrospective milestone. But practically speaking, for anyone over 45, the diagnostic rules completely shift.
Yes, they do.
You are diagnosed entirely by your live symptoms,
Hmm.
the systemic inflammation, the mood changes, the tissue atrophy, not by a snapshot blood test of a shouting brain.
Unless your timeline shifts. If you are under 45 experiencing early menopause or POI, or if you undergo surgical menopause, the blood tests and immediate preventative medical interventions become the absolute standard protocol.
It is a profound departure from how we view almost every other medical condition. The X-ray is out, and the lived experience is in.
It really is.
Well, we want to thank you for joining us on this deep dive. Navigating these conflicting studies and shifting guidelines isn't easy, but having the map makes all the difference.
And before we close, if we connect everything we've discussed today to the broader human experience, I want to leave you with a final biological reality to mull over.
What's that?
We established that the average age of natural menopause is 51. But as human life expectancy continues to rise well into the 80s, that means women are now living a third to perhaps half of their entire lives in a postmenopausal state.
Wait, half of their entire lifespan?
Yes, half. Therefore, menopause isn't simply a brief midlife transition to just grit your teeth and get through. It is a permanent baseline physiological state for a massive portion of the human lifespan.
That is a huge perspective shift.
It completely reframes how we must view postmenopausal health in modern medicine. It's not the end of a reproductive era. It's the beginning of an entirely new, multi-decade biological baseline that requires maintenance, targeted care, and above all, profound understanding.